Welcome to part 4 of the 4-part video series entitled Medical Mycology from the Perspective of the Dermatologist. I'm Maria Catherina Latherin. Opportunistic mycosis. The development of opportunistic infections are determined by the underlying predisposing condition of the host. Candida and related yeasts are endogenous opportunists since they belong to the normal mammalian microbiota. Other opportunistic mycoses are caused by exogenous fungi, which are globally present in soil, water, and air. For this lecture, we will focus on the more common pathogens, mainly Candida, Cryptococcus, Aspergillus, mucormycosis, pneumocystis, and Thalaromycosis. We begin with candidiasis. Several species of the yeast genus Candida are capable of causing candidiasis. They belong to the normal flora of the skin, mucous membranes, and gastrointestinal tract. They colonize the mucosal surfaces of all humans soon after birth. Candidiasis is the most prevalent systemic mycosis, with the most common agents being Candida albicans, parasilosis, glabrata, and tropicalis, among others. Widespread use of fluconazole has given rise to azole-resistant species. In culture or tissue, Candida species grow as oval budding yeast cells. They also form pseudohyphae when the buds continue to grow but fail to detach, producing chains of elongated cells that are pinched or constricted at the septations between cells. Only C. albicans is dimorphic among all species of Candida. In addition to yeast and pseudohyphae, it also can produce true hyphae. On agar media, they produce soft, cream-colored colonies with a yeasty odor. In other words, it smells like beer. Two simple morphologic tests distinguish C. albicans from other species. After incubation in serum for about 90 minutes at 37 degrees centigrade, yeast cells of C. albicans will begin to form true hyphae or germ tubes. And on nutritionally deficient media, it produces large spherical chlamydospores. Sugar fermentation and assimilation tests can be used to confirm the identification of other species of Candida. Increase in number of local Candida and damage to the skin that permits local invasion by yeast and pseudohyphae give rise to cutaneous or mucosal candidiasis. Use of broad-spectrum antibacterials often promotes large increases in endogenous population of Candida in the GIT, oral, and vaginal mucosa. Systemic candidiasis occurs when Candida enters the bloodstream and the innate phagocytic host defenses are inadequate to contain the growth and dissemination of the yeast. The critical host defense against systemic candidiasis is an adequate number of functional neutrophils capable of ingesting and killing the yeast cells. Candida cells elaborate polysaccharides, proteins, and glycoproteins that not only stimulate host defenses but facilitate the attachment and invasion of host cells. Candida also produce agglutinin-like sequence, or your ALS, surface glycoproteins, some of which are adhesins that bind host cell membrane receptors and mediate attachment to epithelial or endothelial cells. Other virulence factors include secreted aspartyl proteinases, SAP, that are able to degrade host cell membranes and destroy immunoglobulins. Also phospholipase, PLB1, which is secreted by yeast and pseudohyphae. They also produce biofilms, which are protected by extracellular matrix material that resists penetration by host immune responses and antifungal drugs. Risk factors associated with superficial candidiasis include AIDS, pregnancy, diabetes, young or old age, birth control pills, and trauma. Candida can present as primary or secondary mycotic infection. In the oropharynx, thrush can occur on the tongue, lips, gums, or palate. It presents as patchy to confluent whitish pseudomembranous lesions composed of epithelial cells, yeasts, and pseudohyphae, which can lead to formation of an intractable biofilm. Yeast invasion of the vaginal mucosa leads to vulvovaginitis, characterized by irritation, pruritus, and vaginal discharge. Intertiginous infection occurs in moist, warm parts of the body, such as the axilla, groin, and intergluteal or inframammary folds. It can be seen in obese and diabetic individuals. Newborns having no established balanced microbiome are susceptible to extensive diaper rash and skin infection by Candida. Interdigital lesions between fingers may be seen following repeated prolonged immersion in water. Invasion of the nails and around the nail plate can give rise to onychomycosis. These are other forms of candidiasis based on anatomic location. Specimens include skin and nail scrapings, fluid, and tissue. Direct microscopy will reveal budding yeast cells and pseudohyphae. Yeast colonies are examined for the presence of pseudohyphae. They are further examined for the presence of germ tubes or chlamydospores. Interpretation of positive cultures varies with the specimen. Any positive culture from a normally sterile body site is significant. For example, sputum cultures have no value because Candida is part of the oral microbiota. Yeast isolates can be speciated phenotypically by using any of several commercial kits to test for the metabolic assimilation of a battery of organic substrates. Crumb agar is a useful commercial medium for the rapid identification of several Candida species based on fungal enzymatic action on chromogenic substrates in the medium. After incubation for 1 to 4 days on crumb agar, colonies of albicans are green, tropicalis is blue, paracellosis and cruzae are pinkish. Thrush and other mucocutaneous forms of candidiasis are usually treated with topical nystatin or oral ketoconazole or fluconazole. Eliminating contributing factors like excessive moisture or antibacterial drugs will help in accelerating resolution of skin lesions. Systemic candidiasis is treated with amphotericin B with or without oral flucytosine, fluconazole, or capsofungin. The most important preventive measure is to avoid disturbing the normal balance of microbiota and intact host defenses. Candidiasis is not communicable since virtually all persons normally harbor the organism. Cryptococcosis is caused by Cryptococcus. Unlike other pathogenic fungi, these yeast cells possess large polysaccharide capsules. Cryptococcus neoformans occurs worldwide in nature and is isolated readily from dry pigeon feces as well as on trees, soil, and other sites. Cryptococcus neoformans is inhaled, and from the lungs, these neurotropic yeasts typically migrate to the CNS, where they cause meningoencephalitis. And it also has the capacity to infect other organs. In culture, Cryptococcus species produce whitish mucoid colonies within 2 to 3 days. On microscopic evaluation, the spherical budding yeast cells are surrounded by a thick non-staining capsule. All species are encapsulated and possess urease. The capsular polysaccharides, regardless of serotype, have similar structure. They are long unbranched polymers consisting of alpha-1,3 linked polymannose backbone with beta-linked monomeric branches of xylose and glucuronic acid. During infection, the capsular polysaccharide or your glucuronosylomannan or your GXM is solubilized in spinal fluid, serum, or urine. This can be detected by an enzyme immunoassay or by agglutination of latex particles coated with antibody to the polysaccharide. Infection starts with inhalation of yeast cells from environment. They are usually dry, minimally encapsulated, and easily aerosolized. Primary pulmonary infection may be asymptomatic or present with flu-like symptoms, which often resolve spontaneously. In the immunocompromised, the yeasts may multiply and disseminate to other parts, but with CNS preference. There may be skin lesions, but chronic meningitis, which can resemble brain tumor, brain abscess, degenerative CNS disease, or TB meningitis, is the major clinical manifestation. Course of cryptococcal meningitis may fluctuate over long periods, but untreated cases are ultimately fatal. Specimens include CSF, tissue, exudates. For direct microscopy, specimens are examined in wet mounts, both direct and after mixing with India ink, to delineate the capsule. Tissue sections need special stains and are examined for globose to avoid budding yeast cells surrounded by wide gelatinous capsules. Colonies develop within a few days on most media or at room temperature or 37 degrees centigrade. Media with cyclohexamide should be avoided because it inhibits cryptococcus growth. Cultures can be identified by growth at 37 degrees centigrade and detection of urease. Also, on an appropriate diphenolic substrate, the phenyl oxidase or lactase of C. neoformans produces melanin in the cell walls, and the colonies develop a brown pigment. Tests for GXM or your capsular antigen can be performed on CSF, serum, and urine. The latex slide agglutination test or enzyme immunoassay for cryptococcal antigen is positive in 90% of patients with cryptococcal meningitis. With effective treatment, the antigen titer drops, except in AIDS patients who often maintain high antigen titers for long periods. There's a new test for GXM which utilizes lateral flow assay on a dipstick, which can be placed in serum, CSF, or urine. Combination therapy with amphotericin B and flucytosine has been considered the standard of treatment for cryptococcal meningitis, although addition of flucytosine remains controversial. Inadequately treated AIDS patients will almost always relapse when amphotericin B is withdrawn, and they require suppressive therapy with fluconazole, which offers excellent penetration of the CNS. Bird droppings, particularly pigeon droppings, enrich growth of Cryptococcus neoformans and serve as reservoir. The organism grows luxuriantly in pigeon excreta, but the birds are not infected. Next is aspergillosis. Aspergillus species are ubiquitous saprobes in nature, with Aspergillus fumigatus as the most common human pathogen. Aspergillus species grow rapidly, producing aerial hyphae that bear characteristic conidial structures, which are long conidiophores with terminal vesicles on which phyalides produce bicipital chain of conidia. Species are identified according to morphologic differences in size, shape, texture, and color of the conidia. In the lungs, alveolar macrophages are usually able to engulf and destroy the conidia, but if the affected is immunocompromised, then efficiency is diminished. Conidia could swell and germinate to produce hyphae that have a tendency to invade pre-existing cavities, producing your aspergilloma or fungus ball, or blood vessels. In some atopic individuals, development of IgE antibodies to the surface antigens of Aspergillus conidia elicits an immediate asthmatic reaction upon subsequent exposure. In others, the conidia germinate and hyphae colonize the bronchial tree without invading the lung parenchyma. Normal hosts exposed to massive doses of conidia can develop extrinsic allergic alveolitis. Specimens are sputum, bronchial washings, and tissue biopsies. Blood samples are rarely positive. Colonies are usually fast-growing, white-yellow, yellow-brown, brown to black, or shades of green, and they mostly consist of dense felt of erect conidiophores. KOH of the molds reveal conidiophores that terminate in a vesicle covered with either a single palisade-like layer of phyalides or a layer of subtending cells which bear small whorls of phyalides. Species are identified according to the morphology of their conidial structures. In histologic sections, the hyphae of Aspergillus are seen to be hyaline, septate, and uniform in width and branch dichotomously. The immunodiffusion test for precipitins to Aspergillus fumigatus is positive in more than 80% of patients with aspergilloma or allergic forms of aspergillosis, but antibody tests are not helpful in the diagnosis of invasive aspergillosis. Instead, serologic tests for circulating cell wall galactomannan is diagnostic, although not entirely specific for aspergillosis. Aspergilloma is treated with itraconazole or amphotericin B and surgery. Invasive aspergillosis requires rapid administration of either the native or lipid formulation of amphotericin B or voriconazole, often supplemented with cytokine immunotherapy. Allergic forms of aspergillosis are treated with corticosteroids or disodium chromoglycate. Bone marrow transplant units use air conditioning systems with heavy filters, and monitoring of airborne contaminants should be done. Some patients at risk for invasive aspergillosis are given prophylactic low-dose amphotericin B or itraconazole. We now go to mucormycosis. In the broadest sense, mucormycosis is any infection caused by a member of the zygomycetes family. Zygomycetes are primitive, fast-growing, terrestrial, largely saprophytic fungi with a cosmopolitan distribution. The medically important orders belong to Mucorales. Mucormycosis is often associated with acidotic diabetes, severe burns, and immunosuppression. The major clinical form is rhinocerebral mucormycosis, which results from germination of the sporangiospores in the nasal passages and invasion of the hyphae into the blood vessels, causing thrombosis, infarction, and necrosis. Thoracic mucormycosis follows inhalation of the sporangiospores with invasion of the lung parenchyma and vasculature. Specimens can come from skin scrapings, sputum, and needle biopsies from pulmonary lesions. In tissue sections, you will find broad, infrequently septate, thin-walled hyphae, which often show focal bulbous dilations in irregular branching. They grow rapidly on laboratory media, producing white to gray or brownish abundant cottony or downy colonies. Identification is based on the sporangial structures. Treatment consists of aggressive surgical debridement, topical administration of amphotericin B, and control of the underlying disease. Many patients survive, but there may be residual effects such as partial facial paralysis or loss of an eye. Next, we have pneumocystis. Pneumocystis eurovechiae is the causative organism for pneumocystis pneumonia. It used to be a major cause of death in AIDS patients. Growth in the lung is limited to the surfactant layer above the alveolar epithelium. In non-AIDS patients, infiltration of the alveolar spaces with plasma cells leads to interstitial plasma cell pneumonitis. Plasma cells are absent in AIDS-related pneumocystis pneumonia. Blockage of the oxygen exchange interface results in cyanosis. Pneumocystis cerevisiae is an extracellular pathogen. It has morphologically distinct forms: 1. Thin-walled trophozoites, and 2. Cysts, which are thick-walled, spherical to elliptical, and contain 4 to 8 nuclei. The cysts can be stained with silver stain, toluidine blue, or chalcofluor white. It contains a surface glycoprotein that can be detected in sera from acutely ill or normal individuals. Specimens are bronchoalveolar lavage, biopsy, or induced sputum. A specific monoclonal antibody is available for direct fluorescent examination of specimens. It cannot be cultured. Acute cases are treated with trimethoprim sulfamethoxazole or pentamidine isethionate. No natural reservoir has been demonstrated, and the agent may be obligate member of the normal flora. Mode of infection is unclear, and transmission by aerosol may be possible. Last among the opportunistic systemic mycosis is penicilliosis. Thalaromyces marnifae is the dimorphic mold that causes penicilliosis, which was originally thought to be a species of penicillium. At ambient temperatures, the mold form grows rapidly to develop a green-yellow colony with a diffusible red pigment. The septate branching hyphae produce aerial conidiophores bearing phyalides and bicipital chains of conidia. In tissue, the hyphal forms convert to unicellular yeast-like cells that divide by fission. The major risk for infection is immunodeficiency due to HIV/AIDS, TB, corticosteroid treatment, or lymphoproliferative diseases. Clinical manifestations include fungemia, skin lesions, and systemic involvement of multiple organs. Treatment with a defined course of amphotericin B is followed by itraconazole. Key concepts to remember about opportunistic mycosis are: causes are either normal flora or environmental yeast or molds. Innate host defenses, which are your neutrophils and monocyte, are crucial for protection against systemic candidiasis, invasive aspergillosis, or mucormycosis. Most patients with HIV/AIDS develop mucosal candidiasis. CD4 counts less than 100 cells per microliter are at risk of developing cryptococcosis, pneumocystis pneumonia, aspergillosis, penicilliosis. Diagnosis of invasive aspergillosis or systemic candidiasis is difficult. Successful management of opportunistic mycosis involves early diagnosis, rapid administration of appropriate antifungal therapy, and control of underlying condition or disease. Opportunistic mycosis are rising in immunocompromised patients. Because it is difficult to establish definitive diagnosis early in the course of infection, many high-risk patients are treated empirically or prophylactically with antifungals. However, there is still no consensus on the criteria for the administration of prophylactic antifungal therapy for patients at high risk of invasive mycosis. Most hospitals who have developed their own protocols would give oral fluconazole, others short course low-dose amphotericin B. Our discussion of antifungal chemotherapy for this lecture will be brief and focus mostly on the class, mechanism of action, indication, and side effects. Here's a summary of the antifungals that are administered systemically, and we'll go through them briefly one by one. Amphotericin B is a major polyene antibiotic, which is a metabolite of streptomyces. It is most effective against severe systemic mycosis. It has a broad spectrum and it kills the fungus by forming complexes with the ergosterol in fungal cell membranes, resulting in membrane damage. It has stronger affinity for ergosterol than cholesterol, and this is important because the cholesterol is the predominant sterol in mammalian cell membranes. Flucytosine is the fluorinated derivative of cytosine. It is used primarily together with amphotericin B for treatment of cryptococcosis or candidiasis. It has good tissue penetration, including blood-brain barrier. Flucytosine is transported into fungal cells by permease, converted by cytosine deaminase to 5-FU, and incorporated into 5-fluorodeoxyuracil acid, monophosphate, which in turn interferes with the activity of thymidylate synthetase and DNA synthesis. The azoles have both imidazoles and triazoles, which are used to treat a wide range of systemic and localized fungal infections. They interfere with ergosterol synthesis by blocking the cytochrome P450-dependent 14-alpha demethylation of lanosterol, which is the precursor of ergosterol in fungi. Azoles are fungistatic drugs. Echinocandins are a relatively new class of antifungal agents that perturb the synthesis of pervasive cell wall polysaccharide beta-glucan. The first licensed drug, capsofungin, has shown efficacy against invasive aspergillosis and systemic candidiasis. Crisofulvin is an orally administered antibiotic derived from penicillium. It is used to treat dermatophytosis. It's poorly absorbed and is concentrated in the stratum corneum, where it inhibits hyphal growth. It does so by interacting with microtubules within the fungus and disrupts the mitotic spindle function, resulting in inhibition of growth. Terbinafine is an allylamine drug which blocks ergosterol synthesis by inhibiting squalene epoxidase. It is orally administered to treat dermatophyte infections. Going now to topical antifungals, we start with nystatin, which is a Pauline antibiotic, which is structurally related to amphotericin B with a similar mode of action. It is used to treat local candidal infections of the mouth and vagina. A variety of antifungal azoles are too toxic for systemic use and are available for topical administration. Clotrimazole, myconazole, and other azoles have a broad spectrum of activity. Other topical antifungals like tolnaftate and naftifine are used in the treatment of many dermatophyte infections and tinea versicolor. Key concepts for antifungal chemotherapy are: effective therapy relies on rapid identification of the fungus, administration of the appropriate drug, and management of any underlying disease or condition. The fungicidal Pauline amphotericin B has a broad spectrum with rare resistance. However, renal toxicity and other side effects must be monitored and managed. Azoles are static with limited range of antifungal activity. Echinocandins are static and are proven effective against Candida. This is the end of the 4-part video series entitled Medical Mycology from the Perspective of the Dermatologist. Thank you.